Hi, my name is Emily and I'm going to be running through a focused respiratory assessment and management techniques with you. The chief complaint of our patient. Our patient is a 2-year-old female presenting with 2 days of a loud barking cough, which has worsened tonight. So tonight is night 2. This morning the patient spiked a temperature of 39 degrees, is increasingly irritable and hot to touch. The patient's mum has brought the patient into ED when she noticed that her daughter had developed a loud sound when inhaling, which we have identified as stridor, and her condition has deteriorated. Mum has been administering paracetamol at home to bring the temperature down and assist in symptom management. Past medical history. So due to the age of our patient, she doesn't have a lot of past medical history, so we'll include the birth history here. So the patient was a 38-week-old infant, born 6 pounds 12 ounces by natural delivery and had no complications at birth. The patient now lives with her mother, father and 6-year-old sister. They live in a small rural town, are a close family with supportive extended family. There are several animals present in the home. Neither parent smokes. So the patient has no medical conditions, had all her routine checkups and is immunised up to date. She has no allergies and no respiratory history. So in my workplace, we start off with an ABCDE assessment approach to identify the areas of most concern or areas that need most intervention. So we'll start off with airway. We note that the airway is patent as the patient is still able to speak in single words. So she said, "Mum." She has an audible barking cough and inspiratory stridor at rest. Then we move on to breathing. So the patient has an increased respiratory rate of 32 breaths a minute when she's not crying. There is tracheal tug present. She has marked chest wall retraction. However, she has no signs of hypoxia, so no oxygen is required, and the chest sounds are clear. So we would identify that breathing is the area that needs the most intervention to improve the patient's respiratory function. So we would fix the problems within this area before moving on to the rest, but I'll just touch on the rest in relation to a respiratory assessment. So circulation, blood pressure was not attended as to not upset the child any further. She has a pulse of 130, which could indicate respiratory distress. She's hot to touch, has a temperature of 39 degrees and is irritable and lethargic. A respiratory assessment. So we'll start off with inspection, move on to palpation and percussion, and then finally auscultation. Inspection. So according to best practice by the Royal Children's Hospital, if a child has respiratory distress, a hands-off approach is the best way to assess this child. So most of our assessment findings will come from inspection as to not upset the child any further. So the patient was positioned where she was comfortable without positioning the child. So she was on her mum's lap and then ended up laying in bed when she got tired. The patient is dressed in a nappy and pyjamas, and mum exposed the abdomen and chest for inspection. So the patient is irritable, crying intermittently and noticeably lethargic. She has marked chest wall retraction, but there's bilateral chest expansion, and from inspection the chest looks to be symmetrical. There's no lumps, bruising or abnormal features that we can see. We can see a tracheal tug and nasal flaring present, which is the body's response to trying to draw more air in. So we notice that there is signs of respiratory distress here. The patient is pink and well perfused. There's no signs of hypoxia, but what we would see if there were the patient would be a sort of a grey tinge. There would be blue colouring on finger beds, lips and also the ear in children, and then also inside the mouth. We are unable to visualise the patient's throat without upsetting her further. The patient has noticeable discharge from her nose, but we can't notice any lumps on the neck, which would indicate swollen lymph nodes. The patient's mum reports that the patient hasn't inhaled anything or swallowed anything that could have got stuck in the throat, but again, we can't see this to confirm. So moving on to palpation and percussion, evidence-based practice, like I said, suggests a minimally invasive approach to assessing children with respiratory distress. So we did palpation when the patient was laying in bed. We felt bilateral and symmetrical chest wall inflation, but no tenderness noted, and we did not percuss this child. Auscultation. So this was actually done in two parts for this patient. We did a posterior assessment when the patient was sitting on her mum's lap, and then anteriorly when the patient was laying in bed. We could hear a loud inspiratory stridor and barking cough without the need of a stethoscope. Using the stethoscope, though, we heard no adventitious lung sounds, so the lung sounds clear, which is suggestive of an upper airway problem rather than a lower airway problem, which, if there was a lower airway problem, we would be more likely to see those signs of hypoxia, so we don't have them, suggesting that the patient is getting adequate gas exchange at the capillaries there. So there's symmetrical breath sounds in both lungs, anteriorly and posteriorly as well. Our health priorities. So it's important to identify the areas of most concern, like I said with our ABCDE assessment. So for this patient, our health priorities are to reduce the laryngeal edema, to improve that air exchange through the narrowed upper airway. Also some symptom management, so controlling the fever and irritability will help reduce anxiety and distress in the child, which will help to decrease the respiratory rate and heart rate, allowing for better management of this patient. Our data interpretation. So ultimately, what could all these findings mean? There's a couple of differential diagnoses that could come from these findings that we have, but grouping all the findings together, we can eliminate some of the potential diagnosis. So the fact that there is normal lung sounds and no signs of hypoxia suggests an upper airway condition, like I said before. So that eliminates things like pneumonia, where there's consolidation of the lower lobes in the lungs. The patient having a temperature is indicative of an immune response to a foreign pathogen, so that infection is likely, and it helps to eliminate other differential diagnoses such as having a foreign body obstruction. So the mum said that she wasn't sure if the patient had swallowed anything or inhaled anything, but having this fever and that immune response to an infection can help us eliminate that diagnosis there. Croup can be diagnosed using assessment findings only, which is a possibility from our assessment findings here, but on occasion an X-ray may be performed as well. So a bit about croup. Croup is a viral inflammation of the upper airway, which includes the larynx, trachea and bronchi. So yeah, that upper airway there. This condition usually peaks around night 2 or 3 and presents in 18 to 24-month-old children. So that's why we're thinking croup for this patient. This is the second night, and her condition has got markedly worse, and she is around that 2-year age bracket. She has a barking cough and inspiratory stridor, which is present with croup, and if croup worsens, they may also have a widespread wheeze as well. So croup can normally be managed at home, but if the symptoms worsen, they may require hospitalisation, which is what brought our patient in today. Due to the viral nature of croup, antibiotics have no role in treatment, and oxygen is not indicated unless the child becomes hypoxic in severe croup, which our child wasn't hypoxic. So treatment includes steroids, and for severe croup, nebulized adrenaline may be used, we'll explain why in the next slide. So the pathophysiology of croup. It is a viral infection, like we said, which causes an inflammatory response in that upper airway. This can trigger narrowing of the airway, and further narrowing occurs from inflammatory exudate. So that develops in the subglottic region, or just below, just at the cricoid cartilage there, which is narrower in babies and small children anyway, as their airway is still underdeveloped. So that's the point where it is most vulnerable to obstruction, like we can see. So you can see in the bottom right-hand corner an X-ray there, which could be used to confirm diagnosis, like I said. So the point of using steroids for treatment is to reduce the swelling and edema and widen that airway there to allow for better oxygen, better air exchange, sorry. Conclusion. So our main areas of concern with this patient were reducing the inflammatory response in the upper airway for better air exchange. A hands-off approach was adopted as per best practice. We eliminated differential diagnosis with our assessment findings such as fever and clear lower lobes of the lungs. And steroids with a course of treatment. There was no nebulized adrenaline required, and the patient was able to just be monitored overnight and then was able to return home, which is ultimately the best course of treatment for small children, is to get them home. So thank you for listening.